SAMHSA chose the topic of opioid use disorders and treatment in pregnancy for its National Women's Health Week observance because of current trends in opioid misuse and significant increases in treatment admissions for pregnant women with opioid use disorders. According to our SAMHSA treatment admission data, among pregnant women, the proportion reporting prescription opioid misuse increased from 2% in 1992 to 28% in 2012. Given the increased use of opioids by pregnant women, it won't be a surprise to anyone that more infants are presenting with neonatal opioid withdrawal syndrome, or NOWS, also referred to as neonatal abstinence syndrome, or NAS. A recent article by Tolio Patrick et al., published in the New England Journal of Medicine this month, reports that in a sample of hospitals, the admission for NAS in 2004 was 7 per 1,000 cases as compared to 27 per 1,000 cases in 2013. As more health and treatment providers are called upon to meet the needs of pregnant opioid-dependent women and their infants, they're seeking best practice guidance from their professional associations, from colleagues, and federal agencies such as SAMHSA, NIDA, CDC, and others. The purpose of our webinar today is to share information on best practices across time frames of pregnancy, post-delivery, and post-discharge. We've assembled a webinar faculty who has a wealth of knowledge to impart, and it's my privilege to introduce them. I'd like to begin by introducing Dr. Hendree Jones, who is a professor in the Department of Obstetrics and Gynecology in the School of Medicine at the University of North Carolina, Chapel Hill, and Executive Director for Horizons, a comprehensive drug treatment program for pregnant and parenting women and their drug-exposed children. Dr. Jones co-authored the MOTHER study that examined the use of buprenorphine in the treatment of opioid dependency during pregnancy. Dr. Jones is an internationally recognized expert in the development and examination of both behavioral and pharmacological treatments for pregnant women and their children in risky life situations. Dr. Jones will discuss the treatment of opioid use disorders during pregnancy and her work with women at UNC Horizons. Horizons is a program of the Department of Obstetrics and Gynecology at UNC Chapel Hill, and it provides substance abuse treatment for pregnant and parenting women and their children and works collaboratively with multiple service providers to provide a range of services. Following Dr. Jones will be Dr. Carl Seashore, the Medical Director of the Newborn Nursery at UNC Chapel Hill, North Carolina Women's Hospital, where he provides care to babies of women with prenatal substance abuse in collaboration with the UNC Obstetrics Horizons program. Dr. Seashore has recently been involved with a statewide collaborative across North Carolina to improve awareness of opioid dependence and NAS. Dr. Seashore will discuss the impact of prenatal exposure to opioids and share his experience in working with exposed infants in the newborn period and with the Horizons program. After Dr. Seashore, we'll hear from Dr. Ann Johnston, who is Associate Professor of Pediatrics at the University of Vermont College of Medicine in Burlington, Vermont, and Medical Director of the Neonatal Medical Follow-Up Program at the University of Vermont Children's Hospital, also in Burlington. Dr. Johnston serves as the attending neonatologist at the University of Vermont Children's Hospital, where she's a member of the CHARM Collaborative, a group who provides care to infants prenatally exposed to opioids and their mothers. And Dr. Johnston will highlight the features and services available to families through the CHARM program following hospital discharge. As Kimmy mentioned, we're going to have questions at the end of the webinar, the last 15 minutes, so please use the chat box to enter your questions, and we'll hold them to the end. But now I'd like to turn things over to Dr. Hendree Jones.
Thank you so much, Sharon, and happy Women's Health Week to all of our listeners. Before I begin, I definitely want to thank SAMHSA and Sharon for her leadership and the invitation to speak with you today, as well as Nancy Young and her team. So thank you all very much. It is a privilege and an honor to be able to share some of the information about opioid use dependency and treatment in pregnancy. Before I begin, I first and foremost want to thank the study patients and the infants that gave tirelessly of themselves during many of the studies that I'm going to share with you today, particularly the MOTHER study. When we did that study, the FDA did not allow us to provide take-home medication for our women, and so what that meant is that every single day that they were in the study, and some of our women were in the study for over 9 months, they had to come and take their medication. So that meant holidays, birthdays, funerals, everything, and I'm just forever indebted to them for their service and contribution to the field. I also want to thank the National Institute on Drug Abuse for their continued support since 1994 for this type of research, and also to the many PIs and investigative team members that it takes to bring these data to you today. As I'm going to be talking about methadone and buprenorphine for treatment during pregnancy, I think it's important to mention that they have been in Category C, the FDA pregnancy Category C. And I also think that it's important to mention that these medications should not be considered off-label use for the treatment of patients that have opioid use disorder. And that's because these medications aren't likely to have an indication during pregnancy because they are not pregnancy-specific conditions themselves. And finally, I want to thank Rickett and Binkeser Pharmaceuticals because they donated active as well as placebo tablets to our study, our mother study, and the study that predated that one, and for reimbursement for time and travel in 2011. So the objectives of the talk that I have today is to first review the historical as well as current context of opioid use by pregnant women. Then we're going to compare and contrast the risks and benefits of methadone and buprenorphine given during pregnancy in terms of fetal effects, child effects, and maternal effects. And then finally, we'll turn to the Horizons program looking at different types of treatment components for the comprehensive treatment programs that provide medication-assisted treatment. So the outline, we'll just start with the historical and current opioid use, turn to methadone and buprenorphine, and then look at the different types of components of care with UNC Horizons featured. So to put this issue in a historical context, we know that substance use during pregnancy has been a long-standing issue in the United States. And in the 1800s, it was estimated that somewhere between 66 to 75% of those individuals that were using opium were actually women. And Stephen Kendall has got a great book called Substance and Shadow that was published in 1996 that actually does a nice job reviewing this history. And the most common reason that women were prescribed opiates was due to pain treatment and many other types of female-specific issues. Obviously, there are women, when they're using drugs or maintained on opium, some of them are going to get pregnant. And so neonatal withdrawal was recognized early on, and some very forward-thinking physicians recognized that having mothers breastfeed while they were taking opium or morphine and also giving morphine to the child postnatally were ways of preventing both morbidity and mortality. With the passage of the Harrison Narcotics Act in 1914, one of the repercussions of that was that women who had been getting their medication from legitimate sources were really pushed into the shadows and the margins of society, and they were forced to do many behaviors that they wouldn't have normally done in order to continue to access their drugs. If we fast forward to the current context of opioid use during pregnancy, I think it's always important to compare the rates of pregnant women that are using substances to those who are not pregnant. And you'll see in this slide that the most commonly used drugs for non-pregnant women are tobacco in gray and alcohol in the orange. And you can see that that's also true for women who are pregnant, that the tobacco and the alcohol are most commonly used more than the illicit substances. The other thing, as Sharon had alluded to earlier, is that certainly the rates of prescription pain relievers are going up among the general population as well as among pregnant women. And one of the biggest concerns of opioid use during pregnancy is the effects on the fetus and then the neonate. And neonatal opioid withdrawal, also known as neonatal abstinence syndrome, has been defined as occurring when a child is prenatally exposed to an opioid and then is abruptly discontinued from that opioid when the baby is delivered. There are a couple of ramifications that could happen, which include central nervous system dysfunction, meaning the babies might have a high-pitched cry. They might be irritable, which is different from crying. Irritability can be defined as like a negative reaction or a grimace to touch or to light or to other external stimuli. Babies with now might have exaggerated reflexes, they might have tremors, their muscles might be much tighter than other babies, and they might have sleep disturbances. Autonomic system indications might include the fever, the yawning, and sneezing. Babies might have gastrointestinal problems, so they require a lot of time to feed. They might have difficulty keeping food down and projectile vomiting and also having loose stools. And then finally, signs of respiratory distress like nasal stuffiness or rapid breathing. I think it's an important distinction to note that neonatal abstinence syndrome or neonatal opioid withdrawal is not the same as fetal alcohol syndrome. We know that now is a treatable condition, and we do not have any data to conclusively say that there are long-term consequences from either having a NOW or an AF or being treated with medication for the NOW or NAF. These are data that Stephen Patrick was a lead PI and author on, and these data were published in, I believe it was 2012 in JAMA. And what these show is that over the last decade, that if you look at the top, it shows the national weighted estimates of rates of maternal opioid use per 1,000 hospital births per year. And what you can see is a steady increase from 2000 to 2009 in the rates of women who have an opioid use at delivery. If you go down to the bottom panel, you can see the national estimates of the rates of neonatal abstinence syndrome per 1,000 hospital births. And similar to the women's states, you're going to see increased neonatal abstinence syndrome rates too. And then the last panel here, it shows the difference between neonates that had neonatal abstinence syndrome versus those that did not. And you can see that there were babies that had more low birth weight, more respiratory distress, and were also more likely to be covered by Medicaid. The tagline from this study that really sparked a lot of attention and opportunity to really make a difference in this country with neonatal abstinence syndrome was that in the United States, 1 infant every hour suffers from neonatal abstinence syndrome. So why are our rates of opioid use and opioid use disorders rising in the United States for the general population as well as for the pregnant population? It has been estimated that 100 million people in this country have chronic pain and that 7 million misuse prescription pain medications. When we compare the numbers of people that have chronic pain to those that have other chronic conditions, you can see that there is a much larger percentage with chronic pain than with addiction, opioid addiction, diabetes, or depression. So clearly, there is a big market for opioid treatment medications, either treatment for pain or treatment for addiction. One of the other issues that changed in the United States was an increase in access to these medications. There was a lot of attention paid to marketing opioid medications throughout the country. JCAHO noted that pain was our 5th vital sign, so more hospital and medical care practitioners started paying attention to treating or adequately assessing and treating pain. And then we also had many opportunistic people in this country that started opening pain clinics and started doing illegitimate things in order to make money. So just to summarize that historical and current context, we know that while opioid misuse might be less common than either alcohol or tobacco use, it is still a growing and serious issue that we need to pay attention to, and our women and our children deserve treatment. We know that the increase in opiates by pregnant women is driving the increase in incidence of neonatal opioid withdrawal, and we also know that it is very complicated. It is unusual to find a woman who is only using one type of substance. I can tell you at Horizons, over 85% of our women are smoking cigarettes. About 1/3 are using alcohol, another 1/3 are using benzodiazepines. And that drug use is intertwined with complex personal, interpersonal, family, social, and environmental factors that can either contribute to risk or adverse consequences. So I envision the need to treat the whole woman and to treat not only her, but also her child and the dyad uniquely. And with that is a very complex situation. And we require multifaceted interventions to help treat the whole person, the whole child, and the whole couplet. So let's talk about pharmacotherapy. We know that we have decades of research to show that if we provide opioid medication to pregnant women, it's going to lessen the fetal exposure to repeated episodes of highs and then withdrawals. We know that we can prevent exposure to other cutting agents if she is injecting or using other street drugs. We know that opioid medication can reduce the maternal craving and can reduce fetal exposure to other types of drugs. We know with drug abstinence that other behaviors can follow suit. So if she can maintain her opioid dependence and go from addiction to opiate dependence that is controlled and maintained, that she's going to reduce her risk for HIV, she's going to reduce her risk for other sexually transmitted infections, and she's going to have a chance to really focus on the other aspects of life and the root causes that brought her into drug use and into addiction in the first place. And finally, we have very nice data to show that opioid medication in the context of comprehensive care can improve obstetrical outcomes, it can reduce fetal complications, and improve overall outcomes in general. So women often present to treatment with very complex life situations. I can tell you at Horizons, the vast majority of women have been exposed to violence, to physical, sexual, and or emotional abuse in their childhood and into adulthood. Many of our women are not first-generation drug users. I can tell you over 80% of our women have either maternal or father or family history of drug use. Many of our women lack formal education. They've dropped out of high school or haven't otherwise completed other years of education. They often lack legal job skills and job maintenance skills, which I see as two different sets of skills. They are often focused with a lot, or faced with a lot of gender inequality in their life. They have legal involvement, often from Child Protective Services or prostitution charges or other drug-related crimes. They have multiple drug exposures. Many of our women have actually grown up in the foster care system where they've been bounced around and have not had strong or positive supportive parenting models. So part of what we work on is teaching them those parenting skills and helping them to get the resources that they need. They often have a history of child abuse and neglect of their own children as well as in their own past. They can have multiple psychiatric issues. Over 50% of many of our drug-using populations who are women have major depressive disorder. They can have unstable housing, couch surfing, or living really from place to place without a stable address. Sometimes they lack positive relationships or supportive relationships. And I also think it's important to point out that many of them have food insecurity and lack nutritional skills. So they're often used to really eating out of boxes and are unfamiliar with how to cook fresh fruits and vegetables and prepare nutritious meals for themselves and for their children. And I think any of these factors in and of themselves, with or without drug use, certainly can have an influence on both maternal as well as child outcomes. So the role of medication-assisted treatment is very much part of NIDA's effective principles. We know that medication-assisted detoxification, if you are going to use it with a pregnant woman, that is not the first line of treatment that we would suggest, and it should be only considered the first stage in addiction treatment because by itself it does little to change long-term drug use behavior. And when we're talking about it during pregnancy, it's important to think about the mother as well as the fetus. We have data to show that while it is possible to withdraw women from an opiate or from a medication at any trimester in pregnancy, I think the bigger and really important question to ask is why would we want to do this? We know that without incredibly strong, stable support, that 80% of our women are going to relapse back to drug use within a month. And so the WHO guidelines, as well as SAMHSA and other governing bodies and clinical bodies have recommended that opioid medication treatment is really the first line and that we want to avoid opiate detoxification for the vast majority of people. The WHO guidelines were also the first guidelines to suggest that either methadone or buprenorphine treatment can be used with pregnant women. So why else would we want to use opioid medications? I think it's an important distinction, and in terms of language for our field, to note that we are not merely replacing one addiction for another. There's a big difference between being physically dependent on an opioid and being in addiction with an opiate. And so opioid medications are long-acting medications that help control craving. They help control compulsion so that women don't have to spend all of their time seeking drug, using drug, and recovering from drug. The medication also provides control back to the woman so that she can focus on other aspects of her life and help rebuild, help get that job, help put things in place with relationships together so that she can really rebuild her life to the full optimal human potential. And an individual that's receiving opioid pharmacotherapy needs to be monitored by a medical team so that that medical team can evaluate how adequate that medication dosage is for that woman, how her health is, and how her well-being is, not only for herself in the case of pregnancy, also for her fetus. When we think about dosing during pregnancy, there was for many years there was a controversy or a concern in the literature that the more methadone that we might give a woman, the worse we were making the neonatal abstinence syndrome. The most recent data that we have is a systematic review and a meta-analysis which has concluded, and I will quote, Dr. Cleary, that the severity of neonatal abstinence syndrome does not appear to differ according to whether the mothers are on high or low dose methadone maintenance therapy. So what we advocate for our women is that if we are dosing you to the optimal amount, where it's not too much and it's not too little, we are doing the best for her and she's doing the best for her baby. Optimally, we want to be able to split the dose of methadone. We know that methadone, as a small mu opioid agonist, it does have a suppressant effect. And so if we can split the dose, that tends to decrease the sedating effects that it has on the fetus in terms of changing heart rate, vagal tone, or skin conduction, as well as that's for the mother. And then for the fetus, you get less breathing reduction, less movement reduction, and better fetal movement and heart rate coupling. In terms of neonatal abstinence syndrome, if you look across the literature, anywhere between 55 to 90% of babies who are exposed to methadone prenatally have some signs or symptoms of neonatal abstinence syndrome. About 60% require medication. It tends to appear somewhere between 2 to 3 days, and it peaks somewhere between 2 and 5 days. The most common medication for the treatment of NAS is defined as morphine. We're going to hear a lot more about that from our other two speakers. But right now, we don't have one uniform standard accepted protocol, and I'm really hoping in the next couple of years we're going to have some great data and findings that will come out to help guide treatment in this regard. In terms of breastfeeding, methadone is detected in the breast milk, but at low levels. And we also know that we have data to show that methadone can be helpful with reducing some of the severity of NAS. And we know that it's probably not the methadone so much itself in the breast milk, but all of the factors and actions that go around the breastfeeding. So if you're swaddling, if you have that skin-to-skin contact, if you're keeping the light extended, holding that baby, all of those things can be really helpful for NAS reduction. In terms of long-term child development, we don't have a tremendous amount of literature in this way. There's been a little bit of a controversy in the literature with some research showing methadone-exposed school-age children to be less interactive or more aggressive or showing poor achievement compared to children who were not so exposed. However, the most recent data that we have at the meta-analysis showed, and I will quote, no significant impairments for cognitive, psychomotor, or observed behavioral outcomes for chronic intrauterine exposed infants and preschool children compared to non-exposed infants and children. And I think if there's one kind of take-home message from all of the longitudinal studies looking at children following prenatal exposure to any type of substance, it's the postnatal environment that makes the most difference in a child's life in determining resilience or less resilience. So drug exposure can certainly be one factor that makes children more vulnerable to longer-term adverse consequences, but it's one of many other different factors. So just to summarize the methadone portion, we have well over 50 years of documented benefits of methadone during pregnancy. One advantage of methadone is that the induction is relatively simple to do. We know that we need adequate doses to prevent withdrawal and other opioid use. We know that fetal well-being tends to be better with split dosing. However, even with the fetal literature, we really don't know what the long-term outcomes of the differences in fetal behavior might be. We also know that NAS is worse with heavier smoking. And for example, we had data that was published in Drug and Alcohol Dependence showing that it did not matter of the dose of methadone or buprenorphine. What mattered most was the severity of smoking in terms of driving some of the NAS severity, driving low birth weight, and driving prematurity, among other complications. And finally, we know that breastfeeding is compatible with methadone for stabilized women. Now let's look at buprenorphine. It is a Schedule III opioid. It tends to last a little bit longer and is typically dosed once a day. It's typically dosed out of a physician's office where you can get a prescription and then take that prescription home with you. In 2012, we published a review as well as we published 2 reviews actually, and where we just recorded that there were over 40 published reports of prenatal exposure to buprenorphine maintenance. I think if we were to look at the literature now, that number has at least doubled. And we know that the dose range still tends to be pretty stable with looking at 0.4 all the way up to 32 milligrams of buprenorphine exposure in the literature. And that this literature is a relatively messy literature with 88% of those babies being exposed to concomitant drug use, and that is excluding tobacco use. So taking those outcomes together, we know that the research with buprenorphine is not as extensive as it is with methadone for prenatal exposure, but it does tend to be well tolerated and generally safe. It is certainly not worse than methadone, and in a few cases with a few outcomes, it tends to be a little bit better. However, both methadone and buprenorphine are good medications when they are given in appropriate doses and under comprehensive context. In contrast to the research with methadone, there's been less research with buprenorphine to an untreated control group, and that's really because as the research has advanced, it is unethical to have untreated control groups or inadequately treated control groups. So buprenorphine, most often we've had nothing else to compare it to other than the standard of care of methadone. And the majority of the research would suggest that for maternal outcomes in particular, they are not different than they are for methadone, which is good because that gives us 2 options for use in pregnancy. In terms of fetal outcomes, these are data from our mother study, and what you can see is that buprenorphine was more often likely to have a non-reactive stress test, and there was a trend for buprenorphine to have somewhat improved biophysical profile scores, and I think that was really attributed to the idea that methadone as a full mu opioid agonist has more of a suppressant effect than a partial mu agonist with buprenorphine. But again, we don't know what that means for long-term outcomes. In terms of neonatal abstinence syndrome with buprenorphine, the rate for NAS treatment is about 50%, which is roughly the same for methadone, which is 60%. NAS tends to start at about 2 days, and it peaks somewhere between 3 and 4 days. And an exception to this onset would be if benzodiazepines have been noted, where you can have a more longer protracted withdrawal that starts. And then when we were looking at the correlation between buprenorphine dose and NAS severity, that is not inconsistent, and kind of the best data that we have shows that there is not a consistent relationship at all. So again, we advocate for our women what we would advocate with methadone, which is basically we want to treat the woman to the best of our ability. If we're doing that, then we're also doing the best for her fetus. In terms of the first dose of NAS treatment medication, it has been shown to be somewhat later with buprenorphine than with methadone. In one study we had, it was 71 hours versus 34 hours. So that does have an implication in terms of monitoring opioid-exposed neonates, and so keeping the babies in the hospital for at least 3 days, and ideally a little bit longer to observe the possible emergence of NAS is recommended. In terms of breastfeeding, buprenorphine is found in breast milk. However, if you think about it, it's much less oral bioavailable than is methadone. So whatever amount that the baby is getting of buprenorphine in the breast milk, swallowing it, it's being digested and eaten up by the liver. And so the recent guidelines have suggested that the amount of buprenorphine in the human milk is small and unlikely to have negative effects on the developing infant. In terms of child development, the research on the neonatal consequences are certainly limited. We do have unpublished mother data that we're waiting to come out, that we'll be comparing methadone and buprenorphine in children up to 3 years of age. But other than that, there's not a whole lot of data to guide us, so we're still waiting. And I've alluded to the mother study several times. These were the PIs that were a part of our mother study. So we had Johns Hopkins as the lead site. We had Brown University, Thomas Jefferson, the University of Vermont, with Anne will be talking today. We have University of Vienna with Gabrielle Fischer, University of Toronto with Peter Selby, Vanderbilt University with Peter Martin, and Maine State with Susan Stein, and our coordinating center was with Amelia Avia at the University of Maryland. And these are the primary outcome data that we had. And as you can see here, the proportions of babies that were treated for neonatal abstinence syndrome were similar between both methadone and buprenorphine. In terms of the severity, the peak severity of the NAS was also similar between methadone in the green and buprenorphine in the blue. When we looked at the total amount of morphine to treat neonatal abstinence syndrome, that was statistically significantly different, and babies required 89% less morphine to treat their NAS if they were buprenorphine exposed prenatally. They also spent 43% less time in the hospital if they were a buprenorphine exposed baby, and the head circumference was similar between the two groups. The vast majority of other outcome measures that we looked at had very similar outcomes between methadone and buprenorphine. So the other important thing about this study was that this was the first time in a large-scale way that methadone had been examined under double-blind and rigorous conditions. And so it gave us really nice efficacy data for methadone as well as buprenorphine. These are other examples of our secondary outcome measures. And we didn't have differences in any of the other things on the slide. So, in terms of, we were very interested to know what the incidence of NAS signs were between the two types of conditions. And one of the things that we found was that for buprenorphine, more buprenorphine-exposed babies had sneezing, loose stools, and nasal stuffiness compared to our methadone exposed babies. Then when we looked at other aspects of NAS, we found that the methadone-exposed neonates had a higher mean total score for NAS. They also had higher scores for hyperactivity, or hyperactive motor reflex, for disturbed tremors, for undisturbed tremors, to failure to thrive, and excessive irritability. So this gave us an idea of what was really driving the differences in the NAS. So just to summarize the buprenorphine part, as I said before, the mother study really provided the first randomized controlled trial data to support the safety and efficacy of methadone during pregnancy. Our maternal outcome measures that were measured in the mother study were very similar between our medications. Pain management and breastfeeding recommendations are very similar for methadone as well as buprenorphine. And with regard to pain, we know that opioid-dependent women are going to feel pain more. It is not adequate to think that their dose of opioid agonist medication is going to treat their pain. They need and deserve appropriate pain assessment and appropriate pain management. In terms of NAS, we know that buprenorphine can be a frontline medication, but it is not for all women. We know that for women that are stabilized on methadone, they should remain stabilized on methadone unless there's some real huge reason why they should be coming off of it. But it does give us options for treatment. We also know that for NAS treatment and other factors, there are other factors, not just the medication dose, that can either make the NAS worse or can minimize it. And I know our other speakers will talk about that. So just in terms of what those other factors might be, there's some really nice data looking at genetics, There's data looking at cigarette smoking, on benzodiazepine concomitant exposure, on SSRI exposure, and then certainly what protocols we're using in our hospital. Are babies being rooming in with their moms, or are they being separated? We have data from Johns Hopkins as well as Canada showing that if we room in, that the rates of NAS treatment we can cut in half. Also, breastfeeding can minimize the severity of NAS. So we need to be thinking about where our babies are being treated. These were the smoking data that I had alluded to earlier. So what we did is we had both methadone as well as buprenorphine exposed babies in these 4 slides. And we categorized them based on their mother's non-smoking status, smoking below average, which is defined as 6 cigarettes a day, average smoking, which is defined as 14 cigarettes per day, and then above average, which is 21 cigarettes per day. And what you can see is that as the smoking severity increased, the total amount of morphine that was needed to treat the NAS also increased. For the number of days medicated for NAS, as the smoking increased, so did the days go up. In terms of neonatal weight at birth, the non-smoking was they had the heaviest babies, and then as smoking increased, the weight decreased. And the length of hospital stay, as smoking increased, the total length of hospital stay also got longer. And so the take-home message for this is that we need to be thinking, identifying, and aggressively treating smoking in our opioid agonist-maintained moms. So just to summarize the risks and benefits of buprenorphine, we know that availability can be different, with methadone being available in a methadone clinic, buprenorphine most often being available with in an office visit format. Typically, the dosing is daily. Abuse, both medications can be abused. Buprenorphine tends to cost more than methadone does. Both of them are associated with reduced HIV drug risk behaviors. Both are going to increase birth weight better than no treatment. Both are recommended for pregnancy. Both have independent replications of results. Both can have more normalized fetal behavior, particularly with methadone if the dose is split. And certainly there is the drawback of neonatal abstinence syndrome or neonatal opioid withdrawal. But it is an accessible and treatable condition. Now let me move to talking about components for pregnant women. And so we really need to be thinking about the needs of women in all aspects of our program design and delivery. We need to be thinking about where our program is located, how accessible is it, what type of staff do we have, what is the level of empathy of the staff, what kind of program do we want to develop, what is the content, and what is the program material, and are they all trauma-informed, and are they women-centered? We need to do everything we can to provide safe and comfortable environments that honor our women and provide supportive relationships that allow them to really start to address their recovery issues and their needs. And so services that are important to include, obviously, outreach and engagement. This is an incredibly stigmatizing condition, and women need to be able to learn to trust that we are not going to go away and that we have their best interest at heart. We need to provide screening. Obviously, detoxification when it comes to alcohol, benzodiazepines is going to be important. Crisis intervention. Our women have incredibly complex lives. We need to be able to assess the complete person, to assess children, to be able to provide comprehensive treatment planning, and I cannot say enough importance about case management as well as peer support. So let me talk just a little bit about the Horizons program. Our mission is to provide world-class, empowering, and transformative care in an interdisciplinary way to treat women and their children that are affected by substance use disorders. Last year, we treated 233 women, including 57 women with 66 children in our residential program, and 45 of our women in our prenatal care clinic. All of our women are covered by Medicaid or are currently uninsured. Less than, or a little bit more than a third of them have less than a high school education. 40% are pregnant, and 90% of them have children under the age of 18. And half of our women have had recent child protective service involvement. So typically, the women that we would serve have experience with violence and abusive relationships. They often have drug-using partners. They often have no transportation or limited transportation and no stable housing. Many times they have sold their bodies in order to survive and to provide food and shelter for their children and themselves. They often have multiple legal issues tied up with child protective services or drug charges. they have had that experience of being physically, emotionally, and sexually abused, both in childhood and in adulthood. And the most common way that we might find women is that they're referred by Child Protective Services. They're referred from the health department. We also have in North Carolina a 1-800 number, so we get referrals from that line too. And typically she does not have custody of her other children, and so one of the ways that we work with her to help her meet her goals is to get her children back. So our model of care is that we are a trauma-informed program that is intertwined with the addiction treatment. We are women-centered. Women often have relationships that they do their whole life through, and so we work a lot on relationships and becoming the woman that she wants to be. We work on assertive communication skills. We help her with childcare. We help her with transportation. We help her find what type of educational or vocational opportunity that is going to be fulfilling for her. We provide parenting and have a lot of evidence-based curriculums that we use. For example, Circle of Security or Nurturing Parenting and Early Intervention Services. All of our children in our residential settings receive the screening and early intervention services. We have obstetrical care, psychiatry care, and general medical care. And then we have, obviously, residential and outpatient care, depending on the type of service and severity of the woman's needs. So, and we have a substance abuse comprehensive outpatient treatment, as well as a substance abuse intensive outpatient treatment. So we do our best to provide a continuum of care. Elements that are common to both of our services include a big array of our multiple evidence-based practices using contingency management, motivational interviewing, cognitive behavioral therapy, dialectical behavioral therapy, a whole host of other, the matrix model. We have child care, we have psychiatry, case management, individual counseling, parenting, and you can see the rest. Residential programs provide similar sorts of services. We also have peer support that is infused throughout our program, and we have early intervention services for the children. In terms of success, we know that women that have completed our program through an outpatient woman, 75% of our families have positive changes in Child Protective Services. And for our residential program, for 2 years running, 100% of our families that have graduated that have positive outcomes with CPS. That means that cases are closed and recovery is, and reunification with children are regained. In terms of our birth outcomes, we have looked at the state average compared to the Horizons average, and we actually do quite well with only 1.5% of our babies being born premature, 5.5% of our babies being born of low birth weight, and that looks much greater, much more improved when you compare it to a similar untreated drug-exposed condition. Our revenue is primarily from state and federal grants, and we've done some rough cost estimates showing that this is a very effective program, saving the North Carolina taxpayers lots of financial funds. So just to end, our model of care is to provide excellent clinical service for our women and our children, to generate new knowledge, and then finally teach and disseminate that knowledge so that future generations can contribute to the additional and optimal well-being of women and children. And with that, I will end, and thank you very much.
Thank you, Dr. Jones. That was an excellent overview of the issues in pregnancy and during treatment. And we've gotten quite a lot of questions during your presentation. I'm going to hold them to the end so that we can now hear from Dr. Seashore. And I'll turn over to him, and hopefully he has control of the slides.
I hope everyone can hear me, and thank you for the opportunity to speak to you all today. And it's an honor, certainly, to be surrounded by two excellent co-panelists. And I'm thrilled to see that so many folks have an interest in improving our understanding of neonatal abstinence syndrome, as well as opiate misuse and abuse, especially among women during this Women's Health Week. So I'm a pediatrician here in Chapel Hill and medical director of the newborn nursery. And in that role, I work closely with families, mothers, and babies who are impacted by NAS. I teach medical students and residents about this and many other topics, and I am very fortunate to be able to work so closely with Andre. And I can tell you from our experiences working with families together that it is much easier to care for these women and families when they are engaged in a program such as Horizons compared to when we're facing mothers who are navigating the challenges of addiction and are not enrolled in such comprehensive care. I have no disclosures to make, financial or otherwise, but the use of these medications in infants is technically off-label, although as Dr. Jones reviewed already, reasonably well studied and generally regarded as safe. Our goals today are to help you all recognize that neonatal abstinence syndrome is an important public health problem. We see it day to day in the lives of individual patients and families, but the impact on public health and the importance of that can't be understated. I hope we'll understand when and why infants may be at risk for NAS, and then the approach to treatment of infants at risk and exhibiting symptoms of withdrawal. So in the interest of background, Dr. Jones covered this all the way back to the 1800s, and this is not a new problem, but here's a quote. During the past decade, narcotic addiction in the United States has reached epidemic proportions. I think it's true today, but what's ironic about this is it was taken from a paper by Loretta Finnegan published in 1975 in the International Journal of Clinical Pharmacology. So this is a problem we're facing again, but it has different characteristics. In the 70s, heroin was the leading substance or opiate of abuse, and the pattern of narcotic abuse was much more centered in inner cities and urban environments such as New York and Philadelphia, where Finnegan's study was done. In her paper, it was estimated that only 20% of opiate users were women, but a high proportion of those were pregnant during their opiate use. So some similarities and some differences, and I think it's important to note that. So the explosion more recently, to jump ahead to the current state, this is a slide that I think is very powerful from the CDC Vital Signs, which is a public-facing forum that they host. And from July of 2013, they highlighted the number of deaths, nearly 50,000 among women due to prescription painkiller overdose in a 10-year period, representing a 400% increase in those deaths compared to a more modest, although still significant increase among men. The current data from SAMHSA suggest approximately, or at least 30% of substance users are women, and their usage peaks during childbearing age. And that puts babies today at much more risk for neonatal abstinence syndrome. Dr. Jones showed a 2010 paper by Dr. Patrick, and that group published follow-up information just last week, and I was fortunate to see him present this at a meeting recently. The 2012 is the census data for which NAS incidence was available for this paper, and the other interesting thing that they highlighted was the geographic distribution. I see there's more than 600 people attending, and I have heard from the organizers that most of the country is represented, and so you may see your state and have a sense of how high a rate you have, but it's important to note that with this geographic variation, I think we need to look to the areas of the country that have higher incidences and focus on prevention and treatment strategies, and perhaps look to the areas with lower incidence for what they may be doing to prevent higher rates of NAS. I'm down there in North Carolina in the light gray, and my colleagues to the west are seeing this much more than I. It's important to also note that this paper suggested about 22,000 babies required hospitalization with neonatal abstinence syndrome in 2012 at a cost of nearly $1.5 billion in hospital charges. That doesn't account for additional costs that are borne downstream. And as with previous studies, approximately 80% of the mothers and babies are treated under Medicaid. These patients have more complications, longer hospital stays, and the rate is still rising, as Dr. Jones's slide illustrated, through 2009 into 2012, and we've not seen it peak. And so now is the time to be redoubling our efforts on prevention and treatment. So how do we do that? It takes a team. Neonatal abstinence syndrome can occur in babies whose mothers are using prescribed or illicit opiates of any kind. We can see this in babies whose mothers are using heroin or pills illicitly, in mothers who are prescribed opiates, long and short-acting for chronic pain, and in women who are in medication-assisted treatment receiving methadone or buprenorphine. The patterns The patterns of withdrawal are different and generally relate to the duration of action of those medications. So methadone and buprenorphine are longer acting medications, and so the withdrawal appears generally later in the infant, whereas a woman using heroin, especially in the 3rd trimester near delivery, the baby may withdraw more acutely. As Dr. Jones mentioned in her slides, polysubstance abuse and concomitant nicotine exposure escalates the presentation in the baby. And so ideally, and I put that in parentheses because that's a really hard thing to do, and I don't think we're able to do it in every case. We certainly see babies in our nursery where the use of opiates isn't known until after the baby is born and exhibiting concerning symptoms. And that's a much harder scenario to work through than when the prenatal information is available and a mother is already engaged in treatment. And so you want to make sure that you have good working relationships between your obstetricians and your pediatricians, your family medicine doctors, nurse practitioners, nurses, etc., who are involved in the care of these families, but also your additional community programs, social workers, and if you're fortunate enough to have a program such as Horizons, obviously utilizing them. Early testing of both of the mother during gestation, in addition to testing of mother and baby at delivery, is key to help elucidate prescribed substance use versus illicit substance use and help organize your approach to treatment and evaluation if you detect other substances such as benzodiazepines. And evidence-based protocols for screening do exist that generally reflect the baseline rate of substance abuse in your population. So some birth centers routinely drug screen all moms and babies at delivery because their incidence of substance abuse is very high in their population, and others use a targeted approach. But the presence of a protocol is more likely to yield positive results than if it's left to the clinician judgment on a case-by-case basis. And last and most importantly, and I emphasize this in bold purposefully, is a pain management plan for the mother. Many of these women are very narcotic tolerant because of their history. Many of them have chronic pain, and that pain needs to be addressed in the context of a painful process, which childbirth, of course, is. And so whether they've had a vaginal delivery or a cesarean delivery, prospectively thinking about that, working with your anesthesia team and your obstetricians to assure mom's pain is adequately managed is of critical importance. And so how about recognition of NAS? So far I've talked mainly about the point up until the baby is born. And when we're looking at a newborn who is at risk for this, I think it's important to state that prevention and treatment really starts at the moment of birth. Screening protocols, again, looking for the presence of opiates in mother and baby are important, and then scoring tools that evaluate the baby's symptoms of neonatal abstinence, be them neurologic, autonomic, gastrointestinal, or respiratory, as Dr. Jones reviewed. We work hard here at UNC to educate mothers prenatally about neonatal abstinence syndrome, what symptoms are common in NAS, and that their adherence to treatment does not guarantee that their baby won't have NAS, and even the most compliant patients can still have a baby who exhibits NAS that requires treatment. However, by empowering mothers with prenatal education, our hope is that we help her and her family to help the baby, and they can focus on non-pharmacologic treatments such as swaddling, holding the baby skin to skin, keeping the lights dim, keeping the television off. I was rounding in the nursery this morning, and I always find it as a joyful moment to walk into a room and have the TV not on, and it was wonderful to see that today. But it's of critical importance in these babies' rooms. The loud noises and flashing lights are intense stimuli for their brains to process, and so it's an easy thing to eliminate, but it's just as easily overlooked. Dr. Jones also mentioned the compatibility of breastfeeding with mothers who are compliant with their therapy and not using illicitly. This is likely not medication effect in the breast milk, but rather the art and act of breastfeeding, comforting that baby and being supportive and offering non-pharmacologic treatment through the bonding that it supports. I think as providers, whether it's nurses, doctors, or others caring for the dyad, modeling these soothing techniques and teaching them to families is also critical, since many of these mothers were never shown that in their own upbringing. One way we've extended that in our nursery is to take the modified Finnegan scale, which was best validated in the mother study, and translate it into plain English and offer it to the parents on a dry erase clipboard with a marker where they can take notes about how their baby is doing in the times that a nurse is not present in the room. We offer rooming in care for these families with routine care on our postpartum unit, and the nurses simply check in more frequently and perform the withdrawal scoring on a regular basis. This tool has preliminarily shown that it's a way to start a conversation and empower a mother to be more involved in her baby's care and more aware of normal symptoms that the baby might be experiencing as being a newborn versus symptoms of neonatal abstinence syndrome. We've also found that some mothers find it a bit overwhelming to have a clipboard and notes to take, and so we don't require them to do this. We simply offer it as a tool that they can use to complement their baby's care if they find it helpful. Another novel treatment that's come out of our statewide collaborative, which I'll mention again in a few minutes, is the implementation of dual nurse scoring of babies who are exhibiting symptoms of withdrawal, so that an inexperienced or less experienced nurse can learn from a more experienced colleague, and a baby can be evaluated independently by two people to inform decision-making rather than just one. And that has led to increased confidence among nurses on our unit in caring for these babies. So I mentioned the screening tools. It's really critical to use a standardized screening tool for these at-risk infants. Finnegan, or the modified version of it, is the most widely used, but there are others, including the Lipsitz and the Neonatal Withdrawal Inventory. These and variations of them have been studied in various network settings, and the take-home message is often that the use of a protocol, no matter which one it is more important than trying to treat these babies without a protocol. My current concern with these is that none have been validated in the electronic health record era, and none have really been extensively evaluated in a rooming in situation. And so I think this is a ripe area for study and an important area for future research. It's also important to note that the scores that are assigned to a baby using this tool are not the only thing that should drive treatment. Clinical judgment and other factors, such as polysubstance abuse, must come into play, and the clinicians caring for these babies need to exercise their clinical judgment in evaluating whether an infant whose scores may be high, in fact, does not need escalation to pharmacotherapy, and at the same time an infant whose scores may be low, in fact, perhaps due to growth failure or another reason, may benefit from pharmacotherapy. So management of these babies, I can't emphasize enough the importance of non-pharmacologic treatment. This was noted by Finnegan in 1975, and it remains true today. Skin-to-skin time between mother and baby, starting from the moment of birth, initiation of breastfeeding if the use is not illicit, just can't be overestimated in terms of their importance. To illustrate that, a study out of Australia nearly a decade ago now, you can see in the highlighted red box the babies who were breastfed had much lower incidence of pharmacologic treatment for NAS than those who weren't. Swaddling, teaching parents soothing and coping skills I mentioned briefly before, and again, minimizing external stimuli. It's such a simple thing to overlook in the room that multiple visitors, lights, television, loud noises, all exacerbate the baby's experience of withdrawal and perhaps might inhibit mom's comfort with breastfeeding, and those things can compound each other. So ensuring a private and calm environment for these women is of the utmost importance. Once we get to pharmacologic treatment, babies who are having issues with growing, babies who are exhibiting severe symptoms of withdrawal over time, morphine oral solution is the standard first line. The dosing regimens for this vary, but again, the take-home message is the use of a protocol to drive dosing and dose adjustments is the most important thing. What the protocol says is less important than it's being present and followed. The range is written there. That's from Academy of Pediatrics recommendations. And the mother study did a nice job of looking at weight-based versus symptom-based dosing of morphine. Some centers are using methadone, and there is a long list of second-line agents that often come into play, especially in babies with who are exposed to polysubstance abuse. I don't think there's a single right way to treat this because the geographic variations in where and who's caring for these babies are what they are. And so each institution who is dealing with this needs to find what works in their community, who the experts are that they have access to, and what type of protocol they can implement. Again, the escalation and weaning of the medication dosage is based on scoring as well as the baby's growth and general well-being. I mentioned there are secondary agents. Clonidine is commonly used as an adjuvant therapy, and its first-line use is rare. And then we'll hear from our next speaker about the use of methadone and the ability to continue treatment at home, which depends on the program she will present. It's also important to emphasize to these moms that the introduction of medication doesn't mean they should stop the non-pharmacological intervention. So continuing to breastfeed, continuing to provide that low stimulatory environment continues to be important. Rooming in therapy, if it can be offered, again, that's very geographically variable, but if you can keep mom and baby together, that mom can be medicine for her baby and help prevent NAS from worsening. Referral and long-term follow-up will be covered by our next speaker in much more detail, but at minimum, if you don't have access to such a wonderful comprehensive program as they do in Vermont, referral to early intervention, involvement of the Child Development Service agencies or other local resources such as occupational and physical therapy are all indicated. These folks provide eyes in the home and a resource for parents to ask questions and seek access to more care. The medication-assisted treatment programs. We want to make sure that mom's treatment doesn't end in labor and delivery and with her discharge. And I can't say how fortunate I feel to have the Horizons program here at UNC, which makes that so much more comprehensive. And then, of course, finding an appropriate PCP for the baby who can provide ongoing care. The last referral and long-term management slide, DSS involvement or Child Protective Services was mentioned by Dr. Jones. I always emphasize in this scenario that these services should and can be viewed as supportive rather than punitive. That is not how most mothers feel with their experience of perhaps losing children in the past. But these folks are an important part of the community who can help moms work towards reunification with their children, and also will help detect active illicit use, which would escalate their involvement. But the mom's past history really precludes acceptance, unfortunately, in many cases. And then it's great if these children can have access to preschool when they turn 3. The last thing I want to highlight is that we are very fortunate here in North Carolina to have the Perinatal Quality Collaborative of North Carolina. That is a network of birth hospitals across the state, and it has engaged in many state-level quality improvement projects focusing on improving pregnancy and birth outcomes in our state. Many, many other states, Ohio, California, Vermont, certainly have examples of these, and I would encourage the audience to look in your state or region for an improvement collaborative you might be able to join so you have support in instituting change and improving care. And I think with that, I will turn my slides on to the next presenter.
Thank you very much, Dr. Seashore, for taking us through the post-delivery phases. And now I'm going to ask Dr. Johnston to talk a little bit about post-discharge of mother and baby.
Hello, everyone, and thank you so much, Carl, for dealing with the inpatient management in such depth. And Andre, as always, it was so comprehensive and great to hear you. I'm going to be talking about our specific neonatal antenatal approach to the pregnant opioid-dependent woman at the University of Vermont. And I'm just going to talk briefly about that because you've heard from others what a comprehensive approach is. I'm going to talk about the choice of methadone for our inpatient and outpatient treatment, which has been somewhat controversial to others over the years. And I'm going to talk about our outcomes here. Our governor, who is Peter Shumlin, you know, we have a very small state, but it was a little over a year and a half ago that he highlighted opiate abuse in particular and opiate treatment as major concerns for the state, which was music to our ears who were working in this field in terms of the allocation of more resources. And it's not, you know, if you remember Carl Seashore's slide, Vermont has a heavier per capita use of opiates, and I recently heard that dealers really have favored Vermont because it is not as packed with other dealers who they're competing with. It's easy to get, it's fairly rural, it's easy to get young kids interested in becoming dealers themselves, and it's not as violent, so it's safer. Now, this was somebody who knew a drug dealer who told me all this. And that's where I get my information, is from people on the ground sometimes. So I'm not going to go over the whole program that we have, but I will share with you some data later on in this presentation. But one of the things that we recognized is that we needed to meet with these women prenatally. Not only did they get prenatal care within our institution from Marge Meyer and her colleagues, who's maternal fetal medicine, but that we actually needed to set up a meeting with them. And part of that is their fear. And I think that a lot of people are affected by fear, and pregnant opioid-dependent women in particular are filled with shame, not trusting, because it hasn't paid well to trust anybody. So we try to actually establish a connection with them. We provide them written information in the form of a care notebook, which, as Carl said, is so helpful to inform them of the scoring tool that we will be using and give them some descriptions of the different components of the scoring tool so that they're able to participate in their child's care, and it isn't that they go out for a cigarette and their child gets transferred to our NICU where the child receives treatment. We don't want that. We want them to be full on with the treatment plan, and we want to provide them the education before. I think breastfeeding is what it's all about. When I started in this, I thought anything we can do to promote attachment in these families, and there's so many aspects to attachment, parent-child attachment, but the low-hanging fruit, I feel, is breastfeeding. So we always ask the questions, what is the risk of not breastfeeding? And we really use those antenatal visits to clear up some misconceptions about breastfeeding, as I know Dr. Seashore mentioned. So one of the things when we're meeting with these women is our focus, and I mean it used to be our focus, but it tends to be healthcare professionals are so focused on the truth. What is the truth? And so this cartoon, which says, I swear to tell the truth, the whole truth, and nothing but the truth from my perspective, really resonates. A lot of these women will tell you what you think is the truth because it is so all-encompassing, but it's only a truth that they feel comfortable with telling you, and it may be as far as they know the truth, but they don't even know their own truth at that time. So I have really tried, and we have tried as a team, to decrease the emphasis that, oh, she said this, she's lying, but instead encourage her to be more open, and also when she tells us her story, to allow that story to change so that she's not fixed to that story. So what we do in this care notebook is we actually have stories from other patients all the way back to 2000, and these are mothers. We're encouraging fathers and grandparents to put in their stories too, so somebody can relate to them, and we do this in the care notebook. We also learned from Hendree and the folks down at the Center for Addiction and Pregnancy about celebrations and how to how to celebrate different facets of a mother's journey through this. clinic, and we actually celebrate with hearts the first visit after the baby is born, and these are hearts that we've made as team members, and we enclose a little card with that which just says we honor your recovery and congratulating you on this. And I think a lot of these have impact because this is a population that has been so marginalized, that feels so guilty and shamed, that they are surprised to be respected and surprised to be acknowledged for their multiple strengths. What are the benefits and risks of newborn outpatient treatment program with methadone? So the benefits are that we get the babies out sooner. You'll see our length of stay, but it is approximately 7 days. We have a slow wean of methadone, which reduces the symptoms of withdrawal, so that we're not trying to get a baby off and still have them irritable. As a matter of fact, the length of time they're on methadone, you'll see, is about 3 months. Tried all kinds of approaches to this, and this seems to work the best for most patients. I think that it allows for more breastfeeding success when they're not in the fishbowl and when they're able to actually be with their baby at home, and it empowers them in the care for their baby. The safety concerns, of course, are an overdose to the baby, use by others, although it's a very small amount of methadone that we prescribe, so it probably isn't that useful, but if you're an addict that's desperate, you may want to take that baby's methadone. The long half-life may lead to over-medication in the hospital. We've seen that. We can have a baby get lethargic and then be taken off methadone and may not even require it again, but it's sometimes difficult to pick that up, and the parents are the most apt to pick up over-medication and lethargy. There's often a prolonged course, and then the big question, of course, comes, are we treating normal baby irritability with methadone? And I think that's always a question in the back of our minds, and I have really skilled people, including somebody who's online right now, their nurse clinician, who can really help decipher what is normal baby behavior, and she does this on the phone. When we treat with methadone, and from our experience of treating by weight, we also arrived at some standard methadone doses depending on the severity of withdrawal. We have an initial dose of 0.3 milligrams to 0.6 milligrams. I also think it's safer to have standard methadone doses, so this is not by weight. And we started off Q12 hours, depending on the severity of symptoms. We do give extra doses of whatever dose we're giving to try and capture them early, but we try not to increase the actual dose we're giving because that can catch up with you. As I said, one has to watch out for lethargy, and one has to be on a stable dose for at least 48 hours prior to discharge. We have extensive family teaching regarding measurement of methadone dose. A lot of the patients can be quite handy with needles and syringes, but are not as handy with measuring the dose. And so we have a lot of conversation about that. To us, the safety of this is paramount. So how we administer and measure methadone is through this syringe connected to another syringe, so we can tell how much methadone is left over easily, and so that when they come to clinic, we can always measure how much is there and also know how much to prescribe. So what we teach them is how to use this. It is not child-proof, so we encourage all of them to get lock boxes or lock bags. And they basically use this little 1 ml slip-tip syringe, and we've tried other syringes like Luer locks, and the methadone gets wasted in them. And this is an example of a mother giving a dose to her baby. So we would not be able to do this if it weren't for our infrastructure in our clinic. It started off very small scale. It was easy to keep track of patients. We are a little larger scale now, but we need to have the ability to keep track of these patients and know where they are, and we follow them up frequently, every 1 to 2 weeks, primarily 2 weeks when they're stable on their dose. We have close relationships with obstetrics, substance abuse treatment providers, WIC, Child Protective Services, and home health nursing. We also use a single pharmacy to dispense the methadone so that it's dispensed in the same way each time. We have to be very careful about the attachments of the syringes. We've learned from mistakes so that we don't get wastage of methadone. And we have them take a photograph of methadone with their cell phone, which everybody has, so that we can see what happened. You can see that our clinic staff is comprised of this. I'm sorry, we have a new medical assistant now who's right in the middle, and I'll apologize to her. And we really keep very close track as we can of these patients so that we can follow them up thoroughly and be safe about it. We have our first clinic visit, which is the neonatal medical follow-up clinic. We've shortened it to NeoMed, within a week of discharge when they're on methadone, or even if they're not on methadone. We follow up all infants because they remain at risk, and we have very close relationship with our Child Protective Services. Infants requiring medication for NAS are seen at least every 2 weeks, and infants not requiring treatment follow up monthly for the first 4 months, and then we spread it out to every 2 to 4 months until 12 to 18 months. The reason we go as long as 18 months, and sometimes we go longer because of patient ties to us, is that many of them are hepatitis C exposed, and we do hepatitis C antibody screening at 18 months. We do Bailey 3 scales at 8 to 10 months, and we were doing it on every infant, whether they were treated with methadone or not. Now we are just scheduling this development on infants that receive treatment. We do hepatitis C antibody screening, as I mentioned, at 18 months, and we have the CHARM team, which some of you have heard about, which stands for Children and Recovering Mothers, which is multidisciplinary, and Sally Borden, who's spoken nationally on this, has talked about how we got this group together to be able to work together to provide the best care for these mothers and infants. In speaking specifically about infants on methadone, as I said, we have the first visit within a week to 10 days. They must bring their methadone to clinic, and we document how much is remaining. We usually have the caregiver demonstrate with a syringe in air how much methadone they are administering. I try not to ask them what the dose is because I want to see what they're measuring, and it's just a double check. We've had parents that have been unable very early on in this process to be able to tell us the dose, and then they're less able to be able to measure it, and despite having been trained. And usually what turns out for those parents is that they may be giving some PRN dosing, and they're giving a little more here or there for more irritability. Obviously, very dangerous practice. We have learned from some of these experiences very early on that if they can't show us what they're giving immediately, that we're pretty alarmed. We have the caregiver just demonstrate other doses to make sure that they're comfortable with the dosing, and we review the storage, need for additional syringes, who is measuring and administering medicine. And we encourage them to call it medicine, too, with their other children who may be in the home, so that there's not a wide variety of people that get to know that there's methadone in that home. We work collaboratively, really, with the family to agree on a methadone weaning plan. We used to just do this wean that was fairly rapid every other day. This was in the early days of this, 15 years ago. And we have now arrived at the usual weans, which is 0.02 milligrams or mLs every Monday and Thursday, or 0.02 milligrams every Monday. We like to have the same days as weaning days, partly because then we're all speaking the same language, and we can, if I get a call at night about a baby that is weaning, I can know exactly, are you on a Monday wean or Monday, Thursday wean, and so you're about to go down tomorrow. And we really think the consistency and the protocol, as Carl said, is essential to us maintaining safe care. We provide a written schedule for the weaning, and we have them call us if they're going to change that schedule, if they would like to change that schedule at all, so that we can work through that. The next slide is a sample weaning schedule for a patient. And I'm sorry, I just took a picture of the screen, so it doesn't come out that well. But it really gives you what we write out in clinic, and then we actually go over with them in clinic, and then it's printed out for them. It also helps for the primary care provider to see where they are in their wean plan. We use only one concentration, 1 milligram per ml. Very dangerous to use any other concentrations we found. We use only one pharmacy. We used to prescribe like a week worth, and now we prescribe 3 to 4 weeks. We treat infants that are quite far away. We're treating north central Vermont and in northern New York. As you saw, we dispense in a syringe connected to another syringe, and of course recommend lockbox or lock bag to store methadone. We used to provide it free of charge. We're not able to do that anymore. So in reviewing our data, we actually had one patient in 2000, and then in 2002 we had approximately 12, and you can see that it's gone up since then. I think the recent decrease probably means nothing, but we have trained other hospitals to take care of, throughout the state, to take care of the infants with NOWs or NAS, and they do inpatient treatment with morphine, and they use the mother protocol for that, which we've taught them. And I just feel I never advise anybody going into this unless they have an incredible infrastructure, one consistent physician, etc. If you look at our population of infants born to women on methadone or buprenorphine at delivery, you can see buprenorphine dominates. And it dominates partly because we had no methadone clinic until about 2002 and in the state. And we now have several methadone clinics, but we were actually led into buprenorphine fairly soon, even before the mother study, because we didn't have an ability for women to be able to get to methadone treatment clinics. And then we had one, and that was in Burlington, and this was a lot of travel for many, many women across the state. This is interesting. And this is actually the percentage of infants who received pharmacologic therapy. And as you know, and what Andre said, was about 60% of infants require treatment as a whole. But in our hands, we have some hypotheses for this. It really is down to about 20 to 25%. Now you'll see two different lines there, and the red is overlapping the blue at the beginning. We have some infants, and those are the blue lines, that get started on methadone, get sleepy, get discontinued, and therefore don't even get any methadone at discharge. We've observed them for a while, and many of them don't need any methadone at discharge. So that explains that. So really it's 20% in 2014. We have several explanations for this. Better use of non-pharmacologic treatment, as Carl talked about. We really focus on this in our prenatal visits with them and talk about not having visitors unless they can be quiet, unless they can know. Also, don't have any visitors who don't know why they're being scored. Now that doesn't always work. That's up to them in terms of their divulging, but we really try to use that antenatal time as a time to be able to explain with them to their family what this is all about. And we encourage them to share that care notebook which explains it with their family. I think we have less subjectivity in NAS scoring. First of all, through participation in the mother study, there was a lot of emphasis on being consistent in NAS scoring. And then I think what's happened is there's just a decreased assumption of the need for treatment. And of course, when we started, it was very high. Nobody knew. They thought, oh my God, this woman is on 200 milligrams of methadone. For sure, this baby's going to need it. And of course, there is not a dose relationship with the incidence of needing treatment for NAS. Now, although the mother study did not show any difference in needing, as Andre showed you, in buprenorphine versus methadone treatment, in terms of needing treatment for NAS, that is a possibility in this if it's non-blinded and you know that they're on buprenorphine. So I would say that it's down to 20%, partly because people are really, and parents are much better educated about this. We have many parents that's their second or third time through that they still have their children in custody, and some of them are even planned pregnancies. So if you look at our mean hospital length of stay, we vary around 6, actually, it's 5 to 6 for infants treated with methadone, both inpatient and outpatient. That's the blue line. And if you I just took the mother study data, which was an average of 16 days hospitalization for morphine-treated infants, and I think that some places will report 20, 16, and obviously huge ranges. But there is, of course, a large difference with that. That doesn't mean we're advocating this for everybody, because to be safe, you can't just, take our dosages and just do it. You've got to have a mechanism in place. And I've heard that people have looked online at what we do through the University of Vermont, and that scares me, because I don't think it can always be that safe if you don't have the infrastructure. Our mean length of treatment, of course, we had very few infants in the beginning, and I'm just going to say this, we really didn't know what we were doing. We were, learning from patient to patient to patient, so that we had pretty long mean length of stays at the beginning. And what we have come to is an average of just a little over 3 months. Some people think that's too long. We have, in view of that, done a lot of developmental testing on these babies, albeit at very early age, 8 to 10 months of age. But, I'm not sure that there's any evidence that this prolonged course is affecting them, but I think we constantly have to ask the question. And then where the money is, I think, in terms of this population. If there's one thing we can do for them is reverse some of their preconceptions about breastfeeding. And this is breastfeeding at hospital discharge. It doesn't really mean that they're breastfeeding necessarily at 3 months, at 6 months, and some of them are exclusively breastfeeding, and it's wonderful to see. I think that some of the failure to continue to breastfeed is based on the expectations of multiple appointments in multiple places. People are doing a much better job with case management around that, and we're trying to ensure that that doesn't happen at the expense of breastfeeding. But you can imagine that's a concern. So we haven't made much headway in the past several years. And so we're really working on this, because I think that if we can get more to initiate, at least we're past that component. And we all know the reasons that women don't. I mean, a lot of what we hear is, I don't want my baby to be exposed to methadone or buprenorphine any longer than the gestation. I poisoned them, is what they will say, for 9 months. I don't want them to have to experience that anymore. And of course we try to deal with that misconception and emphasize the importance of breastfeeding. This is a look at some of our Bailey 3 composite scores at 7 to 14 months. Sometimes we don't get them in right away at 10 months or 8 to 10 months. And you can see that the percentile ranks, if you look at that down on the bottom, for cognitive, they're at the 66th percentile. Some people have misinterpreted it and thought that this was their score. It is not their score. It is, out of 100 babies, they are doing better than 66 in terms of cognitive development. Language, 62.7, and for motor, 60. And these are just term infants born at our hospital, not referred in, that we chose to look at. And the percentile ranks are similar for those who were treated with methadone. So this is all comers exposed to methadone or buprenorphine in utero, and then we have also looked at the methadone treated babies with similar results. We also have some outcomes that we don't like, and it wouldn't be fair to give you all the positives without the concerns we've had. We've tracked deaths up to 2 years in these infants since the year 2000, and we've had 1,208 opioid-exposed newborns that we've tracked. And as you can see, I've circled them in red. The major cause of death, or factor, I should say, in death has been shared sleeping. We also have a smattering of other. And then we recently, a year ago, had in our population had a head injury that was not accidental, probably caused by the mother at 14 months. And that actually generated a huge political flurry of activity. This issue in Vermont was then condensed by legislators and so on to heroin use and a mother kills a baby, and so we have tried to present all of the other data that this is our first one out of 1,208, albeit a tragedy, a total tragedy. So in summary, our average length of treatment is 3.2 months in 2014. We've had no infant deaths from methadone overdose, which is something that we have, that's something that would be unacceptable. One infant who received PRN doses had a dysconjugate gaze, slightly lethargic, resolved immediately when the weaning schedule was adhered to, with a little help from Child Protection Services. One infant transitioned over to oral morphine, and this is interesting due to the parents being convinced that a baby can't wean any lower than a certain dose of methadone. And of course, the way to get any information to other families is through your patients. And so there's a lot of good information that is shared peer-to-peer. There's often some information that probably doesn't bear much scientific value that's also shared. And so there were a group of parents who knew each other and said, you can't get below this dose. What we did is we took a hospitalization that the baby had for something else, and we transitioned over to morphine and did a wean within 2 weeks. And it was really just resetting the parents' expectations. We did have an infant that required overnight hospitalization due to overdose by a grandmother who had not been trained, and so now we try to train anybody who is going to be giving the methadone. So we have learned from experience, and so some other centers that are following our protocol, we like to share this with them. As a rule, parents do not use their infant's methadone. They are usually on medication-assisted treatment themselves. One always has to be aware of PRN dosing of methadone by family. And as I mentioned, if a family cannot demonstrate the dose consistently, they may be altering the dose at their discretion. And as I've mentioned, if a spill occurs, have them take a picture with their cell phone. Always encourage that the caregiver has been trained in accurate methadone measurement. And you really need to have a very close relationship with Child Protective Services and be available for foster parent training. There's nothing worse than a removal of a child and then they're in a foster family who doesn't know how to do this, so we actually are available to our Child Protective Services to do that training and demonstrate how. So overall, we have a CHARM team, which I've said is Children of Recovering Mothers, that meets monthly and has multiple agencies involved and is impaneled as a child protection team. We have noted some high-risk factors that still seem to be true: an increased distance to a treatment center. If they discontinue methadone or buprenorphine, that obviously concerns us very much, whether they are being actively discontinued from treatment or whether they're choosing to do it themselves. If they have an actively using partner or an abusive relationship with the partner. What we have noted, and all of our staff have noted, and it's been very fulfilling for not only the residents and medical students here, but also for multiple other physicians, that these women respond so well to positive interactions with healthcare providers that we can add so much to their recovery just by having a positive, trauma-informed interaction with them. Finally, I would like to acknowledge not only my team members and multiple agencies here, but also the infants and families we have had the pleasure of caring for. We are learning from them daily. Thank you.
Thank you very much, Dr. Johnston. And I just want to echo the comments that have been coming in through the chat box about the excellent quality of all of these presentations. They really have been excellent. And we've gotten so many questions coming in. I hope that we can get through quite a number of them. If the speakers would indulge me, I'd like to ask that only one speaker responds to each question so that we can get through as many of the questions as possible, and we'll do it sort of in a rapid-fire way where I'll ask the question and jump in if you think this question's for you. As you can imagine, they came in the order that the speakers were speaking, so the early questions mostly I think were for Dr. Jones, and then as time went on we got questions for Dr. Seashore and for Dr. Johnston, so I think you'll recognize the question that's intended for you. I'm going to skip around a bit. I'll start with the early ones and then I'm going to get to some of the ones that came at the end and keep moving through the list, so we'll see how far we can get in the remaining time. Before I do that, I just wanted to let everybody know that we'll be posting the webinar within 24 hours, and that there will be an evaluation sent to you, and we really hope that everyone will fill that out. It helps us very much with our planning, so please consider doing that. Also want to thank Children and Family Futures for hosting the webinar today and organizing it so well as they always do. Also want to let you know that you can go to on the SAMHSA website at the National Center for Substance Use and Child Welfare, .samhsa.gov. There's a lot of resources on this topic, and you see the slide right now that shows you how you can get some more information on this topic if it's something that you want to pursue. So with that, I want to go right into the questions, and I hope that all of our speakers are unmuted so that they can jump right in when I ask it. So the first question, I think this really was for Dr. Jones. Dr. Jones, how can you determine whether someone is misusing methadone or being prescribed the appropriate amount?
I think in part it's first and foremost a conversation with the patient. I think Anne did a fabulous job talking about truth with a capital T and what that looks like versus the patient's perception of truth versus what our provider perception of truth is. So, and I think asking questions about how the methadone is fitting, or buprenorphine, because both can be misused, how that's fitting into the patient's life. Are we seeing, are multiple observers seeing signs of sedation, signs of over-medication? Are patients nodding out? If that is the case, I think it's really important not to just go directly to reducing the dose, but we need to look at, could there be interactions with other medications? Could there be a sleep deprivation that's happening? Could there be some other type of medical co-occurring issue? So looking at for signs of over-sedation, as well as having a conversation. You can also draw blood levels to see if the dose is in the appropriate range.
Okay. And another one for you. What is the data on whether use of benzodiazepines while in methadone treatment is appropriate?
So a lot of the concerns around the combination of methadone and benzodiazepines, and this is also true for buprenorphine and benzodiazepines, really has to do with both medications, the combination of medications being suppressive. And so we're worried about risk of overdose. So many programs, methadone programs, have gone to like a zero tolerance for benzodiazepines. So we really need to be careful first and foremost with that safety piece in mind, and I think that's really what's driving a lot of those policies.
Okay, two more for you. What is the purpose of split dosing?
Purpose of split dosing, I apologize for not clarifying that earlier. So split dose is defined when you have a total daily dose of methadone, and then you would take half of it, like ideally in the morning, and then half of it 12 hours later. That's what a split dose would be. The idea behind that is you're evening out the blood levels in the patient. So this happens sometimes. The patients have differences in metabolism, but particularly for a pregnant patient, you can keep a dose at a more even keel with the woman if you're dividing the total daily dose in half and giving it twice a day. The disadvantages of doing split dosing, obviously, if the woman has to come to the clinic twice a day, that can add a tremendous amount of burden for her as well as for the patient staff. So sometimes what's done is they give the first dose is observed, and then the second part of the dose might be given as a take-home.
Okay. One more for you before I skip around. What is the impact if a pregnant woman stops taking methadone?
That can be depending on her the duration of how long she's been taking it, the dose. It can you can set a woman up for an adverse outcome. So we want to be very careful and not abruptly discontinue that methadone. But if that methadone must be discontinued for some unusual reason, we want to do that in a very gradual and controlled way. Certainly there's a risk for relapse too, and if she's discontinued, that could be a period of vulnerability which could make her at risk for potentially an overdose.
Okay, very good. Dr. Johnston, I think these are for you. Is methadone the first line of treatment for babies with NAS?
No. I think it's one of the possibilities. I mean, the standard of care is short-acting opiates, and such as morphine or dilute tincture of opium. Those are the standard. I think that this is an alternative, but you can't just use the medication as a treatment. You have to actually have the infrastructure, as I mentioned. It would not be safe to just have individual pediatricians managing the methadone. Not that pediatricians can't do it. They can, but it would, I think that there would be a more likelihood of errors happening, and so I think it takes the support staff's presence and comfort with the questions that come in from patients. And we're in a lot of phone contact with patients in between visits.
Okay, excellent. Here's another question for you. What do you do if the mom can't show you the dose administered to her baby?
Well, these days, having learned from that, we would notify child protection, but we might even admit that baby if we're not sure what she's giving. I have to say we haven't run into it in, that's something that we might consider doing, because on an emergent basis, that might be the best thing to do. Mm-hmm. They need to be able to show you what they're giving, and that would be a great concern if they can't.
Thank you. Dr. Seashore, how does use of MAT in pregnancy interact with child maltreatment laws on prenatal exposure? Several of the questioners mentioned it was cause for automatic removal in their state.
It's a great question and a complicated one to answer. There have been several states that have recently introduced legislation attempting to address this problem in the legal system, and there is currently legislation that's been proposed in North Carolina, about which I know more of the specifics. The law that has been proposed in North Carolina does have a stipulation that excludes women who are in active treatment from punitive action in the setting of that prescribed opiate use in the replacement, like we've been talking about. But overall, I think they're trying to address illicit use of substances and adverse neonatal outcomes that are a result of those. And as I hope everyone's heard today, the outcomes are worse in women who are using substances illicitly. I don't think there's much evidence that incarceration is a great treatment for drug dependence, though. And so, getting these women into treatment, I think, is really what we should be thinking about from an advocacy perspective. And as a pediatrician, I think that advocating for mothers and babies to not be separated, especially in the setting of a mother who is in treatment, is really critical. But I would encourage the audience to seek out their state law specifically and understand it and learn it. And if it is doing more harm than good, take advocacy steps in whatever way they can to try to get the legislation amended.
Thank you very much. Another question, is prenatal screening, what is recommended for prenatal screening and what is covered by Medicaid?
If the questioner meant toxicology screening to detect substance abuse during pregnancy, that's typically done with urine toxicology screening in the mother, and that is covered as part of routine pregnancy care. The developmental screening that Dr. Johnson was talking about is also accepted practice in the case of pediatric follow-up, if that was the intent of the question.
Yeah, not entirely sure. How about non-toxicological screening?
So that would be using validated instruments to assess a mother's substance abuse, and there are several of those that are part of standard prenatal practice.
Right.
But perhaps not utilized as widely as they should be.
Okay. I'm looking at the time. We have 1 minute longer. I guess with my last minute, I will just ask any of the speakers if there's a burning point that they wanted to make before we close.
I saw several questions about fetal alcohol syndrome disorders and screening for those, which is off topic, and I would just encourage the folks who ask those questions to look at both SAMHSA and the American Academy of Pediatrics, both of which have fantastic toolkits and references for fetal alcohol spectrum disorders, which weren't the topic today, but also are very important.
I guess for me, Ann Johnston, I usually mention this in talks. I think the critical thing for the health of the baby, for the health of all of these babies, is to improve the health and get the mother healthy. If we forget about, if we don't do that, we're denying good health for the baby.
And Dr. Jones, do you have any parting words?
I guess just to reiterate the fact that not to forget where our women come from and the experiences that they bring and the fear they bring into any medical situation. And we've had great success, especially with giving regular in-services to our nursing team to help them better understand the context for many of our women's behaviors that can, on the surface, seem really problematic and troublesome and confusing. And so I would just advocate for nursing education about addiction and its treatment, and the same for any type of medical provider that's working with a woman of childbearing age.
Okay, thank you so very much. And I just want to remind the audience that we have additional resources, including another 3-part webinar series that's posted on our website. We will have a forthcoming document about collaboration on opioid-dependent pregnant women and child welfare coming out later this year, and encourage you to use those resources. Thank you very much, everybody, for your attendance today. We had over 600 people participating, and we know this is an important issue that we'll continue to work on. So thank you to our speakers, and everybody, thank you very much. Enjoy National Women's Health Week. Bye-bye.